We don't care as long as it works. Go high.
Just say that.
You get caught everywhere you go.
All right.
Yep.
I can handle it.
Remember, stay at the podium.
Yes, ma'am.
Okay.
I'll give my card. He said he's got hand signals he'll give me. As long as it wasn't inappropriate hand signals, I thought that was fine.
Are we up and running on everything's good? Okay. You want to go ahead and get started and then I'll start coming in?
Sure. All right. Can anybody hear me? Okay, thanks for coming out today. I'm Brian Wade, one of the urologists here at St. Vincent's East, part of Urology Centers of Alabama. There's about 30 of us in our group, and I think Sherry's put a picture of all of our mugs on that on your picture there. But today I'm going to go about telling you about a new treatment option we have for BPH. I'm going to kind of go through all the old treatment options and some updates on those, and then mainly focus on something called UroLift, which is a new option that we have. So just as an overview, so what is the prostate? It is this walnut-sized gland that sits here at the base of the prostate. As you urinate, as a male urinates, it kind of runs through the middle of the prostate. Think of it kind of like a donut, and there's a donut hole in the middle, and we're just urinating through that. Its main purpose is basically to produce a fluid that helps transport sperm during ejaculation. The biggest issue is after you finish having children, it really just causes trouble. And if it lived somewhere else, we just say, hey, let's just get rid of this and be done with it. The problem is it lives around a lot of high-priced real estate. So this is anatomy of the prostate over time. There's basically two growth phases for the prostate. Once you're in your teenage years and it kind of plateaus for 20, 25 years, and then once you get into that 40, 45 and up, that prostate's going to start to grow. And these are those conditions that I talked about. So if you are lucky to live long enough, you will probably have one, if not two of these conditions. So prostatitis is basically just inflammation or swelling of the prostate, and that can be very mild. That can be just some mild frequency urgency all the way up to full-blown fever in the hospital kind of symptoms. Prostate cancer, everybody's kind of heard about that. Another real common thing that we treat. About 1 in 6 men will have prostate cancer. Typically very slow growing, but still very important to screen in the appropriate age groups for this because it is such a common thing. And the main thing we're going to talk about today is the enlargement of the prostate gland. And so each one of these affects it differently, so having one condition does not really mean you're going to have another one or eliminate you from having another condition. So what is BPH? That stands for benign prostatic hyperplasia, and that's just the clinical term we use for an enlarged prostate. It's non-cancerous. It's not an indicator of prostate cancer. PSA is something that we check, and we do talk about that, but it is not something that is just isolated to prostate cancer. If you have an enlarged prostate, we'll also see those numbers go up on those patients as well. So BPH is important. If you look at the top 10 diagnosed diseases in a year, about 13.5% of all the diagnoses that we deal with are going to be enlarged prostate. So it ranks right up there with heart disease, high blood pressure, diabetes. So it is a very common thing. So the biggest thing that we deal with is how much does this affect the patient's quality of life? You know, just having an enlarged prostate does not always mean it's going to be causing issues, but once it starts to cause issues, it really can affect their lifestyle. They'll avoid travel, their leisure activities, they'll use bathroom stalls, but probably the thing that gets patients in the most often is disrupting their sleep patterns, because not only will that interfere with the patient, it also then interferes with the spouse. And once that happens, mama's going to get that patient to the office if they have to get up during the night. So this is just a picture kind of what a normal prostate looks like, and normal bladder here on the left, and then you've got an enlarged prostate here on the right. As it enlarges, it has the potential to put pressure here right on the urethra as it runs through the middle. In general, the size of the prostate does not always correlate with the severity of symptoms. Some guys will have huge prostates, but if all of their prostate growth is in the outside edges, they don't have as many symptoms from that. Where some guys, their initial growth happens to be right here in the middle, those patients are going to present to us much earlier. These are some pictures here that you can kind of see. This is, as we look in with cystoscopy, where we're looking in the bladder, this is sort of what a normal prostate will look like in a younger male, and this is what it looks like from the side view. And as prostate starts to grow, you start to see this enlargement. And then here, as it gets really large, it really kind of blocks off the entire urethra. So what happens if we don't treat it? So if this goes on for years and years, and this is not a fast process, this tends to happen over many, many years, but what will happen is this bladder, which is a muscle, smooth muscle, is always kind of butting heads a little bit with the prostate. And as it starts to do that more and more, over time, this muscle of the bladder will really thicken up. And what the patient feels from that then starts to be not only just obstructive symptoms, where they have weak stream, interrupted stream, don't feel like they empty, then they also start to have irritative symptoms, frequency, urgency, they really have to get to the bathroom in a hurry. And over time, if you don't relieve that obstruction, then this bladder muscle gets so unorganized that the bladder just deteriorates. And then that can cause some symptoms upstream. And that's what we talk about here. So you've got enlargement, which then leads to obstruction, and then these are a lot of times, these are the things people present with, and then we realize, hey, we got a problem here. But UTIs, bladder stones, and those are basically a direct result of not emptying your bladder completely, because males are not going to be real at risk of bladder infections unless you're not emptying very well. So if that happens, we have to start thinking about that. Retention, what we call overflow incontinence, where they're not emptying very well and the bladder will just squeeze so hard that they just empty. And then upstream problems like renal failure. So how is BPH or enlarged prostate diagnosed? Routine kind of stuff to start with. Medical history, exam. In patients that start to have complaining of issues, then we do things like ultrasounds or what's called a post-forward residual, where we can see how well or not well they're emptying their bladder. We do a prostate exam. This gives us a rough estimate on prostate size. It's not going to be 100% accurate, but it does let us know, are we dealing with a normal gland, or are we dealing with something much larger? But of all the things that we'll talk about today, if there's anything to kind of remember, is this IPSS, or the International Prostate Symptom Score. This sheet, which I think there's one in the handout, it's 7 questions, and then the 8th question to ask them how much it bothers them. We give this basically to all of our patients over the age of 40 or 45, because you know how men are. You're gonna ask them, hey, how you doing? They're gonna say, oh, I'm fine. You get this score sheet to them, and a lot of these guys will have significant symptoms, but they tell you they're fine. And so it really kind of helps drive us to say, all right, you're not doing as well as you probably think you are. We've got some pretty good options, because what we don't want to do is wait until their bladder is already starting to have deterioration, and then sometimes it's hard to play catch up. But no matter what their score is, this bottom question, how much it bothers them, really kind of drives what we do. So so those questions are going to be, basically all related to how they urinate. How frequently do they go? How urgently do they have to go? Do they have to get up at night? How weak is their stream? Do they feel like they empty? Those kind of questions. And then depending on what their score is, depending on how much it bothers them, you fall into a mild, moderate, or severe symptoms. But this quality of life is important, because no really matter what their score is, some guys will start to have more bother at a lower score, and those patients will treat a little bit differently. So it's just really important for us to get that score sheet on them. And it also gives us a number then to track them after we treat them. So depending on how they're progressing through their treatments, if they're not getting the results that we want or that they want, then that's when we do a little more involved testing. What's called uroflow, which is basically a flow rate, urodynamics, where we can actually place a catheter in the bladder and fill that bladder up. And then the catheter is connected to a computer readout, and it lets us know, is their bladder behaving like it's supposed to. And then if we need to assess this patient for potential treatment options after medication, this is the 2 main tests that we do: an ultrasound of the prostate and cystoscopy. And what this ultrasound lets us do is really get an accurate measurement on how big their prostate is. I tell the patients, I say, there's no such thing as a small prostate. You either have normal, or you've got large, or double X, or triple X. It really just goes up. And cystoscopy helps us not only to look at the prostatic urethra, but also to look at the bladder. And we can see the muscle of the bladder and see, is it already starting to kind of thicken up. So this was a satisfaction survey based off that score sheet. And what guys will tell us is, nobody really ever asked me, is there something else I'd rather do besides taking these medications? And so we started putting this question at the bottom of and about 65% of men actually were interested in trying something other than medications. They just were tired of the medications, having to take them, the cost, side effects, etc. And so it lets us know that a lot of patients really are interested in other options. So out of the 12 million men that have prostate, they kind of fall into these categories. We're going to either keep an eye on them, and that's what we'll do, check them once a year. If it's pretty mild, it's a really good option for those guys. You don't always have to treat these patients if their symptoms are mild. We're going to then usually progress to medications. So about 60% will do that. The problem with medications is you're going to have about 23% that then will drop out at some point, either from just non-compliance, they don't like the medications, they don't like the cost, side effects, etc. So then you're going to end up with about 3% that have some sort of either surgery or procedure. So this is kind of how we progress through this. You've got the less invasive options here, watchful waiting, medications, this UroLift, which we'll go into more detail with. And this is where we've always been trying to find something between medications and the more involved things. And we've tried, if you look over the last 40 years, we've tried just about everything. We've steamed it, we've microwaved it, we've heated it. And not that those treatments were bad, we just didn't get great long-term results with those treatments, and so they tend to fall off the to-do list. But we're always kind of looking for the next thing, and this, we've seen really good results with this, and so we're trying to just spread the word. So this goes through those. So watchful waiting, medications. When we talk about medications, we're talking about basically these three things. Alpha blockers, which are the Flomaxes of the world. The way those work is they actually relax where that bladder and prostate kind of junction is, where that initial butting heads happens. It helps relax that. The 5-alpha reductase inhibitors, that's the Proscar, also known as finasteride. Those actually will shrink the prostate. So those are typically something we start either on bigger glands or on guys that have had some initial improvement with alpha blockers, but then their symptoms kind of start to deteriorate, and so we'll add that to that in combination therapy. Saw palmetto is an herb, and it's kind of all over the board. Some people see some improvement with that. There's no real great study that it showed it ever helped anybody, but some patients really will swear that it helps, and we'll talk about that in a minute too. And then we get to the office space. So when medications don't work, then we start offering things like UroLift. These other things, that's microwave, what's called needle ablation, or Resume, which is where we actually steam the prostate. And then if those are not options, then we move to the surgical side. The way we're doing most of the TURPs now is called bipolar TURP. It's basically a high energy. So instead of the traditional cautery type TURP, this is outpatient now, which is pretty amazing compared to what we used to see. And then we also have laser TURPs. And then for the really big glands is this robotic subtotal, and we'll talk about that. So watchful waiting, pretty straightforward. No surgery, it's cheaper, no side effects. Downside of it is a lot of these guys are going to continue to progress over time. So you'll have no real symptom change, but it's fine for the guy who has minimal symptoms to start with. The medications. So advantages, again, no surgery. It does provide typically a significant symptom relief to start with. What will happen over time, though, is because the disadvantages, these patients have to take this medication from now on. And these are not as benign as we used to think they are. They do have some side effects, sexual side effects, ejaculation issues, stuffiness. A lot of guys will complain about, feel like they always have a stuffy nose, the cost, and then over time they will lose some of their effectiveness. The herbal remedies, again, no surgery, no drugs. Somebody pointed out that they do have some side effects with other medications, and it does affect some of their clotting time. And the other thing we kind of watch for, if patients are on it, it does affect their PSA. It will actually bring their PSA down sort of falsely, so we have to factor that into their number. The UroLift. So this procedure is something we can do either in the office or in the outpatient surgery setting. It provides pretty rapid relief, and we've now determined it's pretty durable. We're out to 5-year data on this. It essentially has no side effects. And so any side effect that they see with this, it tends to be very transient. Preserves all sexual function. Sort of a big thing that the patients like is 85% of these patients will not require a catheter. So they'll have this procedure done, we'll fill their bladder up, and most of them will be able to empty right there. The other thing we always look at with these is retreatment rates. So right now we have about a 10 to 13% retreatment rate, which ranks right up there right with TURP, and so we're real happy with the initial start with this UroLift. Disadvantages, like everything, has a few downsides. These tend to be very short-lived. Frequency, urgency, a little burning when they go. Medications usually help that, and it tends to be 2 to 5 days at most. Those things tend to resolve within a few weeks. The one downside of the UroLift is right now it has to be an 80-gram or less prostate, which is still very large. So it's got a pretty wide catch, but nonetheless, if they get bigger than that, this is not a great option for those patients. The thermotherapies, when we talk about thermotherapies, we're talking about microwave, the procedures I mentioned, and then Resume, which is steaming it. It also can be done in office. It does have fewer side effects. Some of the disadvantages with this is we tend to see that it takes longer to get the results that we wanted to from these procedures. It takes a few weeks, sometimes a few months. All of these guys will have a catheter anywhere from sort of 3 to 7 days, and they do have some sexual dysfunction from this. But probably most importantly, why some of them fall out is the retreatment rates, and it's kind of all over the board. It's anywhere from around 25% up to like 70%. And so we really don't want to put somebody who through something that's we're going to have to do something else in a few months anyway. And then the surgical side. So the bipolar TURP, what we call green light, which is our laser, and then the robotic subtotal. Everything really is compared to this because this is what we've been doing for a long time. So it's going to get your maximum flow and your maximum symptom relief because it moves all that tissue out of the way. You're physically either kind of lasering or resecting that tissue out. It's proven to be very durable. These retreatment rates are in the low kind of 5 to 10%. And so everything has to be compared to that. If it doesn't match up with or get close to that, it's not something we're really going to offer in the long term. The disadvantages are fairly straightforward. These require typically anesthetic in the hospital or outpatient surgery setting. They're all going to have a catheter. The newer procedures that we're doing with this, the bipolar TURP, they typically just have to have that catheter one night, which is pretty great compared to where we used to leave them in a few days. They do have some side effects, about 10% risk of erectile issues. About 65% of these men will have ejaculation issues, and that mainly means they have what's called retrograde ejaculation, where that tissue is now gone, and so when they ejaculate, the fluid's going to go into their bladder. It doesn't cause any health issues, but it's different, and then guys just don't like it. Incontinence, and then a slight chance of strictures as well. So I keep talking about this whole sexual side of things, and we talk about it because all these guys that come in and talk to us, they want to know how much this is going to affect it. Because if you look at guys between the ages of 50 and 80, 83% are still sexually active, where you're getting 92% of guys in their 50s, and still even in their 70s, 65% are going to report that they're sexually active. So it's a real question that we have to talk about and let them know things may change depending on what we choose here. So the UroLift. So this is kind of a schematic, and I've got a video I'll show you too. But when the patients come into the office, we give them a mild sedative. We give them either a Valium or we have nitrous gas, so that we get them just take away the anxiety. And then we do a block on their prostate. So we do a prostate block through an ultrasound, so we can numb up all the tissue sort of around it. And then after we have that block done, we place a catheter in the bladder. We place a lidocaine gel into the bladder, and then a viscous lidocaine into the urethra. We're going to let that stay in place for about 15-20 minutes. Once we have that in place, we then take a special cystoscope that's made for this. We place it into the bladder, and then we can fire these devices. They kind of come out as a little needle on the side. It places a little tab on the outside of the prostate. We then compress the prostate tissue and place another one on the inside. I tell folks, think of it kind of like you're taking the curtains and you're just kind of pulling back the curtains like this. Most patients need 4. And this is what the device looks like. It's very small. It's got what's called nitinol, which is a metal that stays on the outside of the prostate. This is a polyester permanent stitch, and then the inside is a stainless steel. We call it the urethral end piece. When we place these, you can see them, but if you go back and look just a couple weeks later, the prostate has actually already grown over that part right there, so it kind of covers them up, so there's no real risk of infection from this. This is the video, and it shows you this is the little device that we place. Let's see here. Oops. So how do I get that to play? Tips, suggestions? Oop. Anybody know how to get this to play? It kind of shows it. I'd like to. I hit next, it just goes to the next slide. Yeah, I'm trying to. I'm not getting an arrow though. There it is. Thanks. Okay. There we go. So it places this needle on the outside edge. We compress the prostate, then we place the inside tab. We remove that piece. Each one of these has an individual load, and so we plate that one out, place another one, basically 180 degrees to the opposite side, place that. And it seems so simple, and you're kind of like, why didn't we do this 100 years ago, but it really is pretty complex process to get this to fire like this. And this is sort of a before and after the way things look. And this is sort of real live picture. So this is what it looked like before. We compressed this tissue out of the way, and now you've got this wide open channel. So expectations. So we tell these guys for a few days afterwards, you're going to have usually an uptick in your symptoms. You'll see a little more frequency possibly, a little more urgency, a little burning, a little blood in the urine just from having the procedure done. That tends to last 2 to 7 days really from what we've seen in real life. These guys are back going full speed real fast. We currently have 5-year data nationwide on their clinical follow-ups. It doesn't mean it's going to last just 5 years. It just means that's what we have so far. It's coming up on 6, and it continues to show good results. So this is a study called the local study, and what this let us know is how fast can these patients get back to doing what they want to do. So these guys are back to work at around 2.8 days, 0% work missed, so most of these guys will have it end of the week and be back to work the following week. It really does not slow these guys down much at all. So we want to compare this to TURP, and what we kind of knew, because this does not take away as much tissue, it doesn't take away any tissue, it just kind of pushes it out of the way. So there are some differences between that symptom score sheet and their max flow rate, which is this kind of Qmax here. But what was important was their quality of life, it matched right up with it. So these guys come back in and they are thrilled with how fast they've gotten back to doing what they want to do, and we're dropping their scores by 15 points in 2 weeks. A little busy slide here, but this basically just shows that the UroLift patients, they recover quicker and they get to their maximum benefit faster. TURP is going to catch up with them eventually, but these guys just bounce back a whole lot faster. This is sort of my data here because we want to track this. We're always skeptical when something new comes out because we've seen all these other things. So this yellow is the original sort of what's called the LIFT study, which showed, hey, this was going to be something we needed to kind of think about. And these are our patients here. So we're starting these guys usually around 22, 23 on their score. And at the 2-week mark, we're dropping about 15 points. And then over time, they were now at to about 1.5 years. But these guys continue to show some improvement in their symptom scores. This slide. So this basically shows us why we like this procedure. The yellow is good. So these are the symptom score improvements with TURP. Down here at the bottom, the Proscar medications, the Flomax medications, and UroLift. So all of them will see some benefit. Everything, again, kind of is compared to this. But the red are the potential side effects. So with UroLift, when I say none, we really don't see any side effects from this. It's 0.7% chance of stricture. And these other ones, they're low risk, and so we use them, but they are real risk factors that we see from them. And again, probably the biggest thing we hear about with the TURPs are the ejaculation issues. I'm just going to touch briefly on the other thing that we're doing now for these really large glands, this robotic subtotal. So people used to call this the simple prostatectomy, which to me was such a misnomer because there was nothing simple about it. It was a big operation, typically a fair amount of blood loss. And this is for the guys when we're evaluating them with the ultrasound and the cysto. Some of these guys will have huge glands. I put on here a greater than 100, it's kind of our baseline, but we've taken out 300-gram prostates on these guys, and it used to be just a much bigger deal. But with this, we use the Da Vinci robot made by Intuitive here, and this is kind of the setup. So you have a console here on the side, and we've been doing this for prostatectomy for prostate cancer for 14 years now, but this kind of came along in not too distant past, and the patient's over here on the table beside. But through these sort of special trocars, we connect the robot to the patient, and then we can take all the instruments and go all the way down to the pelvis where the prostate lives. So with this procedure, I tell patients, think about it like an orange. We're going to unzip your prostate, we're going to unzip your bladder so we can see the top of the orange where the prostate kind of pushes into the bladder. We're then going to open up the rind of that orange, and we're going to take all the pulp out. And we can do that through these instruments, and we can take out these huge glands that way that we can't do any other way. And then we can close the rind back, zip the bladder back up. Catheter stays in for about a week just to really let the bladder heal. These patients just do so much better. They stay in the hospital usually 1 night. We used to leave them in 3 to 5 nights typically. Catheter comes out in a week. Probably the biggest difference is blood loss. The national studies show 200 cc's. We're really probably losing more like 100 now. And we didn't have to really transfuse a lot of the open procedures, but this made patients anemic. They just didn't feel as good. These patients, they come back in a week, we take their catheter out, and they're really back to full speed pretty quick. So it's another great option that we have for the really big glands that we see. So in summary, there's great options out there. They're all going to continue to evolve. In 2 years, there'll be something else that we're kind of doing with this. But right now, we've been real happy with this UroLift for the right guy. Different levels of symptoms are going to, and different levels of bother are really going to how we're going to tailor treatments to these patients. We have seen this with a shift in this paradigm on treating BPH with these more minimally invasive treatments. So instead of waiting until they're at the end of the road where their bladder is really just not working at all, these guys are moving way up on that and saying, hey, instead of taking these medicines, instead of waiting, let's do some of these procedures sooner. Gets them off the medications, which, like I say, are not as benign as we used to think. And not everybody's an option. Not everybody is available for all these options. We'll have patients come in and say, hey, I really want this, and we evaluate them and say, you've got this or this, and you really need to think about this other option instead. But the biggest thing is we've got great options now. And that's pretty much it. Be glad to take questions.
Okay, so you said if it's greater than 80,
Right.
you do it, but is there looking at like doing the microwave first and then when it's time for retreatment, then following up with that if it's shrunk to
Oh, I see what you're saying. You shrink it down. So sometimes we'll put patients on like the finasterides, the proscars, because that will cause some shrinkage. But it's hard. We haven't really done that to try to actually do a microwave or those kind of, because you may not see much shrinkage with that. So you're kind of in that gray zone, and what will probably happen is as we study the UroLift more, that indication is going to get bigger. So you're going to probably close that gap by saying, hey, these patients we can do between 80 and 100 now.
So it's not, because I mean, it looked like from the device that it would just be, that the reason why I couldn't do it on 80 is just it's not long enough.
Right. No, it's just because you have so much obstructive tissue. So, but the ultrasound that we do in the office, they have to be less than 60 millimeters in width. And so, because the needle is only 33 millimeters long. And so, but now we're going to compress it, so you'll lose some of that, but they have to be, but that's a pretty wide prostate. So very few times it's, hey, is it so wide that we can't do it? It's usually just so much tissue.
So do you have a guess as to how long the UroLift is good for?
How long is it good for? So we're approaching 6 year on follow-up. And so far at 6 years, we're seeing it maintain that, again, retreatment rate's about 10 to 13%. And in that 13%, you're going to have some of those patients that did so well the first few years that you'll look back in and say, hey, you just got a little bit of obstructive tissue. We'll go back in and actually, use the UroLift, a new device on that to pin it out of the way and get their symptoms treated that way. So it's not always, hey, you have UroLift and then you have to move on to something else. Some of those guys are actually having it done again. Now, we haven't seen that yet, but you're looking at the 6 year data. That's what some of the patients are doing. Yeah, and so she mentioned Sherry just showed me the symptom score sheet. Again, I encourage you, take that to your office, make some copies, give that to guys. It really will help kind of let you know how the patients are doing, because they're going to tell you they're doing fine when sometimes they're really not doing great. So, all right, I appreciate it.